So it's particularly good to be here. One of the very nice things about this morning is that both Sherry and Arlene got to sleep at home last night, which are rare treats for both of them. Sherry is on this 2-year journey in Washington, for which we're grateful. And in addition to exercising policy leadership, trying to rebuild ASPE, as it's just called, to be an ongoing top quality policy analysis shop for the federal government. It's sort of been on hard times for a while, so we're glad to give you the opportunity to be at home, Sherry. We appreciate that. And for both Arlene and myself, it's really nice to not be in Albany for any period of time at all, so we appreciate all of you for that. So I want to just riff a little bit on, in a sense, beginning with where Sherry left off, on this dynamic of integration and exceptionalism. And it seems to me that in this talk, and in the book even more so, it's a remarkably accessible, read for such a weighty subject. Several things are established very clearly, and one is that things are moving in the direction of integration and away from exceptionalism. It's almost over, but that movement is undeniable. And second, that movement comes with significant benefits and potential risks. And so I want to just reflect on a couple of those risks that are before us, sort of at the national level and in New York. And there's a framework that I'm starting to use in thinking about this, which has to do with the question of, as we proceed in this environment of integration, can we make reasonable accommodations? Reasonable accommodations is, of course, that term that's used in employment law related to the reasonable accommodations that can be made in a work situation for somebody with a disability. And I think it's a good framework for us to use in thinking about keeping or installing what is of value as we go forward now, and illustrate that with a couple of in a sense test cases or test subjects or propositions. Because we all in New York had our experience with integration fast forwarded about a year ago. We have a new governor, and we have a new wonderkind Medicaid director, and of course what we noticed within about 3 nanoseconds of the first assertion by that Medicaid director that all care in Medicaid was going to have to be managed in some fashion. We had people in expensive suits showing up around the Capitol saying, "We're from the health plans and we can take care of that mental health problem for you." So I think the perception in the mental health community was, yes, maybe eventually, but maybe not ready for prime time quite yet. And so we went through that period that was tumultuous, leading to the recommendation of pursuing some kind of specialty management in what I think is inevitably a transitional basis. It's not going to go on forever. And a number of us, including Commissioner Sanchez, as well as Ann, have just been serving all summer on a work group that is fleshing out that direction for specialty management in the mental health substance use disorder arena. So our report, this is the report of the Behavioral Health Subcommittee of the MRT, is not quite yet out. It'll be out within 2 weeks. I think you're going to like it. And I think unless you use it frequently, persistently, energetically, and loudly, the chances are that a number of its recommendations are likely to fall by the wayside. And we think the recommendations are critical to kind of getting this right. So that's at a broad level what our immediate challenges are in New York. I just want to take a couple of case studies, if you will, of the integration debate to ask the question of, is it going to be possible for us to install the reasonable accommodations that are needed for adequate care to be provided? So my first test case, and Ann has already talked about this, Tom has worked on it, Lloyd Setter, who's here, got a lot of this started, has to do with the question of, is it going to be possible to provide a tolerably decent level of care for common mental disorders in the mainstream? Let's just say primary care. There's more to it than primary care. But is it going to be possible? What do we know so far I think what we know so far is that the chances for that are about the same as the chances for any innovation to be adopted. There's a whole body of evidence on under what circumstances people will make a change in their business, in their practice, in their life. And it turns out we will make a change if it's easy, cheap, and we think it's to our relatively immediate benefit. That's essentially what the evidence is. And so the evidence so far on adequate care for common problems like depression or anxiety or ADHD are, if it's easy and cheap, people will try it. For example, if all you have to do is prescribe an SSRI, we'll prescribe an SSRI. So the prevalence of those people with depression who get treatment has doubled in the last 50 years, although it started to go down. I think it's going down because we don't have as much direct-to-consumer marketing, frankly. Whatever you think of it, people aren't asking their doctor about it anymore. So what we saw in 15 years was that the treated prevalence of depression doubled. But as Mark Olson and others have pointed out, in looking at the content of care, the modal experience with that is that people are going to get one or maybe two prescriptions of an SSRI. It's not going to be refilled. They're never going to get up to a therapeutic level. They're going to feel a little bit better and they're going to stop. So the question is, can we take this to the next level or not? And Sherry's point about the necessity of installing better measures is going to be absolutely necessary for us to do this, because we know what it takes to provide good care for those conditions in primary care. It's called collaborative care. It's well studied now, over 40 well-designed studies. And it turns out, and it'll do it pretty well, there are three simple things you got to do. You've got to screen for these conditions. You've got to have a mental health person who is on the floor to assist with the management of the condition and to talk to the patient or consumer. You've got to measure how people are doing, and then you've got to adjust the treatment based on that. So the question is collaborative care going to get installed as the standard of care or not? And I've been, pushing this for some time. It actually turns out was a recommendation of the President's Commission 10 years ago that has not yet been adapted in Medicare. But whether it's Medicare at the national level, and we just had conversations with Don Berwick about this within the last month, or it's Medicaid at the state level, we don't know what the answer to this is, but the question of whether or not it gets adopted is going to be a test of whether we can advance integration in a way that is responsible. I'm going to just jump to one other example of that, something that we're working on, partly because Sherry ended with this point, and I think it's really a significant point that has to do with these disability trends. You saw what they are. They've been accelerating in this economy. But we're in New York in interesting conversations right now with Social Security about this. Social Security has realized that this trend is killing the trust fund. I mean, there's a little bit too much. There's more to it than that. But putting young children who have got a behavioral problem on SSI for life is not inconsequential when they represent now such a high proportion of the people that are coming on disability. And so Social Security has approached us about what I would essentially describe as a gain-sharing arrangement under which we would make some commitments to do a better job of helping people with serious behavioral problems get a job. They would pay us for that. The mechanisms are more complicated than that. And this, for me, is another test case. Are we going to be able to pull this off or not? And I'm at risk even mentioning this because we're working now to get an agreement nailed down with Social Security that will provide for this reinvestment, and we have to get this done before budget finds out about it, or there's zero chance that the money will stay where it needs to be. So the question for us going forward, I think, is whether or not we're going to be able to install reasonable accommodations in these mainstream programs. Our track record of doing that so far is not very good. And I think the next 5 years will be critical in seeing whether or not we're able to do that better.
So now it's me. I have a little PowerPoint